So he talked about the future. Well, actually, if you take the right exit, the future is right here. It's right here. The problem is half the world are practicing in the Stone Age, because the future is already here. Most people, as we see and we heard, are still in the Stone Age. So I have to mention my disclosures, and this becomes kind of important. So the US is a very strange place, actually. They've enacted a legislation called the Sunshine Act or Open Payments Act. And by this act, any physician who receives more than $100 from any pharmaceutical company or medical device company has to be reported to the federal government, and it is provided on the web, accessible to everybody. As a principle, I decided to divorce myself from all pharmaceutical and device biases. So this is my disclosure, as can be seen on the Open Payments Sunshine Act. I receive no payments from anybody, neither myself, my family, or anyone else. So I, in that way, can remain totally independent and objective. So, the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. And it seems like most people just do not want to do that. What they learn, they believe, is sketched in stone, and they believe it and will not unlearn what they've learned, forgetting that most of what we learn, particularly at medical school, is wrong. So it's really important to have a historical perspective on this concept of fluid resuscitation. And really it takes us back to 1831. This is a sketch which was published in the Lancet. I'm sure many remembers reading this. This is a sketch of a girl who died of cholera in the late stages of spasmodic shock. So you can see she's blue, she's cold, and she's hypoperfused. So it's important to remember the treatment of the day, and I think it was endorsed by the Surviving Sepsis campaign, was vivisection. So we have a patient who's in profound hypovolemic shock, and the treatment of the day was vivisection. So then came across Dr. O'Shaughnessy, who actually did some really very interesting data. He did some vivisection and actually looked at these patients and found their blood was profoundly hemoconcentrated and was deprived of alkali. So he thought this was kind of interesting, and you can see he wrote this in a letter to the Lancet in 1831. And then came Dr. Latter, who is recorded as the first person in the history of mankind actually to infuse an intravenous fluid into a patient. And it's really very illustrative to look back at an account of his very first patient. So this is the first patient who ever received an intravenous infusion. It says here intravenous saline, but if you actually look at the composition of the fluid, it's more like half ringers. So his first patient was an elderly woman who had reached the last moments of her earthly existence. Having no precedent to guide me, I proceeded with much caution. Latter inserted a tube into the basilic vein and injected ounce after ounce, closely observing the patient. Okay, I think it's worth repeating. Ounce after ounce of fluid, closely observing the patient. Isn't that a miraculous concept of resuscitation? The sunken eyes, the fallen jaw, the pale and cold extremities bearing the manifest imprint of death's signet began to glow with returning animation. The pulse returned to the wrist. The first case of a human being resuscitated by intravenous fluid, which really tells us the story on how to resuscitate. Because from there we go to what's called the Rivers Protocol, in which we flood patients with liter after liter of fluid. And early goal-directed therapy should be termed iatrogenic saltwater drowning, not resuscitation. And it's led to this concept of de-resuscitation, because we give patients so many liters of fluids. My good friend here, Manny, has now developed a protocol of de-resuscitating patients in whom we have profoundly over-resuscitated. So the bottom line is, I'm kind of simple. This is my friend, Homer. We kind of hang out together. We kind of look the same. So really, the bottom line is you give them as much as they need and not a single drop more. Not a single drop more. The question, obviously, is, when do you know when you've given them enough? And that's what we're going to talk about. So I said, closely observe the patient. Well, I think that's infinitely better than the Rivers approach. And I think in 200 years we've gone backwards with the Rivers approach. But I think this study is really enlightening because, unfortunately, physical examination can be really misleading. So this is data looking at blood loss, looking at the ATLS classification of hemorrhagic shock, class 1, 2, 3, 4. You can see class 4 is patients who have lost greater than 2 liters of blood, and yet the vital signs are normal. So clearly, the latter approach is significantly safer than the Rivers approach, but observing your patient has significant limitations. This is Manny's ambulance. So this is a really interesting study. Physical examination, central venous pressure, chest radiography for the prediction of transpulmonary derived hemodynamic parameters in the ICU. And what they found was physical examination, the CVP, the chest X-ray did not correlate with transpulmonary thermodilution assessment of volume status, preload, or lung water. And it's quite remarkable that people still look at the X-ray. They look at it and they say, oh, patient's volume overloaded or volume depleted, and they make therapeutic decisions based on the chest X-ray. It's a load of hot air. This study, which we can see almost 25 years ago, in which they got expert radiologists to rank the chest X-ray according to the degree of pulmonary edema. They correlated it with lung water measured objectively, and there's no correlation. So trying to decide the patient's volume status on a chest X-ray is just playing darts. So the part of the problem is people ask the wrong question. And clearly, if you ask the wrong question, you're going to get the wrong answer. So the question is, what is the question? Well, here are the wrong questions. And we'll go through some of them. What's the CVP and wedge? The wrong question. Is the tank full? Most times when I look at the patient, I don't see a tank or a gas gauge. So I am unable to tell whether their tank is full or empty. And it's a meaningless concept. What's the cardiac output? In and of itself, it's kind of meaningless. The stroke volume pulse pressure variation in itself has enormous caveats, which we'll talk about. Does the vena cava collapse? It's like Rome collapsing. It's kind of useless. So what is the right question? And really the right question, is my patient fluid responsive? I.e., if I give him fluid, will his cardiac output improve? And where is he on his Frank-Starling curve? It's quite simple. Will the patient respond? And the reason is, there's only one reason to give fluid. It's not to wet the bed, it's to increase stroke volume. And if you don't increase stroke volume, giving fluid serves no purpose. We know if you take all comers, less than 50% of patients will increase their stroke volume in response to a fluid challenge. As we said yesterday, patients in septic shock are profoundly fluid unresponsive. Just throwing in fluid to an unresponsive patient is a very stupid idea. So what you need to do is determine, is your patient fluid responsive? And by fluid responsiveness we mean a significant increase, and the general terminology is 10% increase in stroke volume in response to a fluid challenge, and it only occurs in patients who are biventricular preload responsive. So you can have a normal LV, but your RV can be pretty sick. You give a fluid challenge, you won't respond. In fact, your stroke volume could go down. You have to be biventricular preload responsive. So it's kind of interesting. There's the Frank-Starling curve, they're two famous guys, and then there's the Marik-Phillips curve, which will be famous when the two of us are dead. Anyway, it's kind of interesting how these two curves overlap. So the Frank-Starling curve you know about. The Marik-Phillips curve is your lung water curve in black. So as it so happens, if you are preload responsive, you give a patient a fluid challenge, they have a big increase in cardiac output, a very small increase in lung water. However, as you climb the curve, you get diminishing returns, such that when you get at the top of the curve, you get a tiny increase in cardiac output, but a big increase in lung water, which we know is a bad thing. So as you climb the Frank-Starling curve, you get diminishing returns to the point that it becomes harmful. So clearly what you want to do is give fluid to patients who are at the bottom of the curve and are fluid responsive. So the question is, how can you assess, what are the techniques for fluid responsiveness? So we're going to talk about receiver operating curves, which is a statistical way of telling whether a test is worthless, i.e. useless, or fair, but only works in about maybe 70% of your patients, or really good, which is what I want, which works like in 90% of my patients. I don't want to be wrong half the time. So basically, these are a list of techniques which in red are useless. CVP, IVC, flow time, in orange, IVC diameter, pulse pressure variation. There are only really two techniques which have any degree of accuracy in predicting fluid responsiveness. Passive leg raising and the volume challenge. And these are the technologies which are linked to these two techniques, which we'll talk about. So unfortunately, because of the Surviving Sepsis campaign, the use of the CVP has become ubiquitous across the entire planet. Last year I visited a whole bunch of Asian countries, and apparently they got the 10 Commandments, which tells them, you shall measure the CVP or go to hell. And every single ICU, they measure the CVP and fluid is titrated to the CVP. It's become ubiquitous, and we just saw 80% of you in this room measure the CVP. So why do you do it? So this is a quote. The CVP has been shown to have a poor correlation with effective circulating volume in both absolute value and trends. CVP is often either insensitive or misleading. So when was that quote made? In the American Journal of Surgery in 1983. This concept is not new. This was a study published in 1984 in which they measured blood volume by a radioisotope technique and they plotted CVP. So all the CVP believers in this room can see the perfect statistical association between the CVP and blood volume. And it's important to point out, because people will say if the CVP is low, well, the patient must be volume depleted. And you can see that just is not true. This is from Kaplan's Anesthesia, and he states there's 7 flawed assumptions in assuming that the CVP predicts fluid responsiveness. So we did this meta-analysis in chest, Does the central venous pressure predict fluid responsiveness? Systematic review of the literature and the tale of 7 mares. And what we showed was the CVP and, importantly, the change in CVP. So neither the CVP nor the change in CVP was able to predict volume responsiveness or fluid status. So this is the only study published in the entire universe literature which shows some association between the CVP and blood volume. This study was done in 7 healthy, standing, awake mares. Let's be clear, 7 mares. This is the entire scientific literature on which the central venous pressure is based. So based on this literature, one would assume that people who measure the CVP have an ICU full of horses, because this is the only study which shows some value. So we did another meta-analysis because the first one didn't seem to be good enough, and again showed exactly the same thing. In any group of patients, in any circumstance, the CVP does just not predict fluid responsiveness. This was the editorial by Anand Kumar, who says, blah, 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 we should not be utilizing the CVP to predict volume responsiveness. Utilization of the passive leg maneuver in patients with minimally invasive cardiac output monitoring is probably the best predictor. So unfortunately, what has happened is the CVP has been elevated to beyond science to a religion. It's a religious thing now. I just believe in the CVP. Doesn't matter what you say. People believe in it like they believe in the tooth fairy and they believe in Santa Claus. And I believe, speaking to Canning yesterday, he's actually doing research on Santa Claus, so maybe there actually is a Santa Claus. So it seems to have reached mythical proportions. And this is a press release from Surviving Sepsis campaign released last month, in which they insist the CVP will not be removed. So despite all the evidence, the CVP stays. So that's a picture, if you're not aware of it, of a dead swan. That's what a dead swan looks like. So we need to be absolutely clear. The pulmonary artery catheter does not improve outcome. It provides misleading data. It provides data which physicians and nurses just don't understand. And the more they think they understand it, the less they actually understand. And it's an inaccurate device. So in Australia, they have no shortage of sheep. So they did the study where they put flow probes around the aorta, the best way of measuring cardiac output. They then put in a swan, and they showed the cardiac output has to change by more than 30% for the pulmonary artery catheter to detect a change. However, the pulmonary artery catheter is considered the gold standard. Even today, every paper talks about the gold standard. And the closest the PAC comes to becoming the gold standard is the color of the catheter. Unfortunately, well, fortunately, the poor pulmonary catheter died at a kind of young age, 2013. So quickly talking about heart-lung interactions, my time is kind of running short, so I'm going to go through this quickly, which grab people's attention. The problem is an enormous number of limitations. This is best illustrated by Maxime Cannison's study, who demonstrated in an operating room, in the best of circumstances, in 25% of patients, it's going to be unreliable. In the ICU setting, this study shows in only 2% of patients, 2% of ICU patients actually meet the reliability criteria for stroke volume variation. So as my good friend Bart says, there must be an easier way, and there are. You either do a passive leg raising or you give a fluid challenge. If you give the fluid challenge, it has to be given quickly because, as we heard, the fluid dissipates pretty quickly. So this is the mini fluid challenge. We heard about it earlier. You give 100 mils over a minute, and pretty good way of assessing fluid responsiveness. However, the most simple way is most patients have legs. It's a simple exercise just to lift their legs. Here we have a passive leg raising maneuver. They get a fluid bolus. increased venous return, and within a quick period of time, you can tell if the patient is a fluid responder or a non-responder. It mimics a fluid challenge, but unlike a fluid challenge, no fluid, the effects are reversible and transient. And unlike all the other tests we've seen, this study showed a pretty good accuracy. We used 2 different technologies. They seem to be pretty good. So this is a patient with septic shock on norepinephrine, respiratory failure, acute renal failure. Nephrologists know only 2 things, Lasix and take off fluid. The nephrologist said, take off fluid. We said, wait, let's look at this patient. His JEDI, which is his global volume, was down. His pulse pressure was a bit up. His lung water, which we consider crucial, was 8. So we did a passive leg raising, and I'll show you in 20 seconds we could tell you the answer. Do you want to run the video? Please look at stroke volume index. Starts at 28. You can click the video for me. Okay, 29, 30, 31, 32, 33, 34, 35, 36, 37, 38, 39, 40. So in 15 seconds, the stroke volume went up by 40% just by lifting the patient's legs. Can there be anything more simple than doing that? And in fact, that is the standard of care in our emergency room and in our ICU. The nurses do it unprovoked, unprompted. So when they call the physician, they will say, Mr. So-and-so has such and such. He's a fluid responder or a non-responder. So, just to wrap it up, when you're a fluid responder, what next? Well, maybe you do nothing because you don't need to do anything. Most of you in this room are fluid responders. You certainly don't need a volume challenge. You may have an increased lung water and you don't want to give fluid. You may want to give fluid, but you want to give a small bolus. Giving a liter of fluid results in drowning. Or, as we said yesterday, remarkably, if you're a fluid responder, you may want to give an alpha agonist, which increases venous return and increases stroke volume. If you're a non-responder, well, you've got to look at why the patient's in trouble. You need an echo, and then decide what to do next. And kind of to finish up, it's absolutely essential that whatever you do, you couple this with echo. It's absolutely essential. It's a simple technique that was Yannick Ballou, who was my fellow like 15 years ago, and this is Elisha, a current fellow resident. They can be taught to do basic bedside echo. You cannot do this without echo. So just to summarize hemodynamic monitoring and assessment, the most important part is the brain at the bedside. It's the most important part, that thing there, and it has to be switched on. Having a dull brain that just follows a protocol at the bedside will lead to a bad outcome. So you need to know somebody who understands the patient, understands the hemodynamics, and has his lights switched on. You then integrate the information from your different technologies and then decide what to do in a dynamic process. This is not a once-off thing. And I thank you for your attention.